and we will have a very experts on the topic who are going to talk about their research, and we are going to have a very interesting conversation. And then definitely feel free to ask us questions, feel free to just interact with us. We want to hear from you, and we want to give you this very important information. So my name is Deborah Camille Mukaz. I am a postdoc at the University of Vermont, and part of my work is looking at some of these cardiometabolic disorders like diabetes in a very large cohort of the United States. I'll let my the other moderator, Chichi, introduce herself.
Hello everyone, my name is Chichi Okagwe. I am a second year PhD student at the University of Reading. My PhD project is looking into the biological mechanisms of obesity and how exactly they contribute to cardiovascular disease in a nutshell.
And so Dr. Scott, can you introduce yourself?
Sure. Hi, everyone. So I am Jewel Scott. I'm a postdoc at the University of Pittsburgh. I completed my PhD at Duke University School of Nursing and just graduated this past May during the pandemic. I defended my dissertation during the pandemic remotely as well, and that was quite an experience. My background is as a family nurse practitioner. And so I've worked in primary care, and now I study cardiovascular disease in young adult Black women, and really interested in psychosocial stressors, some of the non-traditional risk factors.
Definitely. So we will have another speaker that is coming. We are all learning how to do all learning about this virtual experience when it comes to hosting some of these events, and she's here. Thank you, Dr. Spikes, and thank you for joining us. And we just introduced Dr. Scott, and could you please introduce yourself, Dr. Spikes?
Hi, good morning. Well, good afternoon now. My name is Talisa Spikes, and I am a second-year postdoctoral fellow in the School of Public Health at Emory. So in the Division of Epidemiology. So honored to be here.
Definitely. Thank you so much for both of you for introducing yourselves. So my first question would be to know, so before we talk about your work and about in cardiometabolic health, could you each tell me how you define cardiometabolic health in layman's terms, because we have a broad audience? How would you define it?
Okay. Well, I didn't know. Okay, I'll go first. So I define cardiometabolic health as health that encompasses both the cardiovascular and metabolic system, which is essentially how our body breaks down food and transform it into energy. This process is also contingent upon other factors such as genetics, diet and nutrition, weight, and activity level.
Definitely.
Yeah,
Dr. Scott?
I agree with, Dr. Spike. It's very similar. I kind of thought about it as breaking down the word cardiometabolic into two different parts. And so that first part, cardio, meaning heart, we see that part very commonly, cardiovascular disease. I think the second part, metabolic, is sometimes what throws people or could be a little confusing. But I think about it really, those smaller scale chemical changes in our body that can put you at risk for disease. For example, thinking about diabetes is one of the most common metabolic diseases that comes to mind. And so that metabolic piece would be kind of how the insulin stops working as well over time, and that leads to diabetes, and diabetes increases the risk for heart disease. And so those two pieces, cardiometabolic, is coming together, combining what happens at the smaller cellular level and how that's related to overall heart health.
Definitely. So my second question would be to know, can you tell me a little bit about, so you mentioned that both of you guys were postdocs and you are doing amazing work. So can you tell me a little bit more about yourself, your background, and your work?
Sure. So I've been a nurse a registered nurse for 16 and a half years. My clinical focus specialized in cardiac ICU. So I've been a cardiac nurse for most of my career. The latter half of my career was spent in management. So I managed and oversaw a 44-bed post-open heart, step-down heart failure transplant unit at the time. And during that time, that's what actually piqued my interest into returning back to school to pursue my PhD. I began to notice an influx of young African-American women admitted into the hospital with diagnosis of heart failure. And when I say young, meaning late 20s, early 30s. And when I would go around on these women, when I had the opportunity to, just to find out, why are you here? You're too young. And one common denominator that most of these women shared was that, well, the doctor told me I had heart failure, but I don't receive it. So this big demonstration of denial coping was a common theme that I noticed amongst all of the groups. So at that point, I decided I really wanted to go back to school to try to find out what was going on. One, these women looked like me, not too far in age from me. So I said, I really want to know what's going on and what can I do to stop the trajectory of them being admitted into the hospital at 20-something years old. No young person should be admitted on a heart failure unit at 29, with sent home with hospice or even being listed on a heart transplant list. And one other thing I wanted to add was that they all shared a common diagnosis of hypertension.
Yeah, very, very similar experience in that my background as a nurse is working for the last almost 15 years as a nurse practitioner in primary care, but I was seeing a similar phenomenon in the outpatient setting. And so I've worked in primary care settings in Chicago, in rural North Carolina, and seeing a lot of really young women with hypertension, with diabetes, often in their 20s, late teens, and some resistance or, denial that I really have hypertension, blood pressure numbers really high, some very difficult to control hypertension. So we're now on 2 or 3 different medications, trying to control blood pressures. And some had traditional risk factors like you would expect, but some did not. And because I was in primary care, I was at the same location for about 6-7 years. I really got to know a lot of my patients, and I was hearing about a lot of about their life experiences, a lot of stress in the home and in the community. And I became really curious about how these social factors were playing into this really early development of hypertension, and with the goal of keeping them from landing on the ICU floor with heart failure and trying to manage this. And so became more interested in the psychosocial impact of chronic stress and how that was affecting this early onset of cardiovascular disease in really young Black women primarily.
Definitely. Chichi, do you have a question that you wanted to ask our participants?
Yes. So, Dr. Scott, it's actually nice that you touched upon the psychosocial risk factors in regards to the young women you've encountered that have hypertension. But also, I would like to know about the diet and physical activity aspects of being risk factors, contributing to cardiometabolic health. And also because both of your work primarily is focused around Black women, young Black women, how do you think racism affects the diet and physical activity of Black people in the US?
Yeah, that is a great question. And a very big question, right? And so just thinking about risk factors, oftentimes we talk about things that are modifiable and things that are not modifiable. So these things that we can change and things that we can't change. I think one of the big non-modifiable is family history. And I think sometimes in our communities we don't always talk about our health history or problems that we have medically. And so I know there's often been a push that around this time of year, as we think about typically, these are obviously COVID times and things are a little bit different, but typically we're thinking about Thanksgiving and Christmas and seeing family, to make sure that we're having some of that dialogue about family history so people are aware of what things they may be at risk of. And so that can also inform how people take care of themselves and help prioritize the need for working on some of the modifiable risk factors. So things like physical activity is a big modifiable risk factor. Thinking about how do we move our bodies more, thinking about, as clinicians, prescriptions for physical activity. And oftentimes with my patients, I would try to decouple or separate physical activity from weight loss, because I think sometimes if people only see physical activity as a means to weight loss, if the scale's not moving, then they think, okay, this is not working, and they give up, right? But I think really talking about like the broad view of what physical activity does in our body, the way that it improves the way that insulin works in the body, and so that decreases your chances of diabetes. It improves our mood, and so that helps with mental health. There's a lot of non-scale benefits of physical activity for cardiovascular health, and I think if we only talk about it in the context of body size, then people, if they don't see that changing, then they think, okay, then there's no point of continuing to do this physical activity, when it's really doing a lot of really good stuff to prevent hypertension and prevent diabetes, or to help manage those things. I can go on to the piece of racism. To me, that's a whole nother question, and I can keep going, or if you want me to pause here, but I think definitely, I feel like there is definitely a connection between racism and these risk behaviors. I think we could, you can think about like the larger societal ways that racism affects health and risk behaviors, but then there's also the individual, level. And so at the individual level, I think as we think about things like diet, being, able to afford fruits and vegetables and foods that may cost a little bit more, thinking about, how people, manage stress when you're living in a society that does not treat you equally or equitably. There's a lot of stress that comes with that. And what do we do with that stress? How do we manage that stress? Part of my research looks at the internalization of stress. So what happens when that stress becomes embodied? It gets within our body and it starts to cause changes in our HPA, our stress axis. And so instead of our body, having moments of calm, sometimes we can stay at this heightened stress level, and that changes the physiology, changes your body, and puts you at risk for cardiometabolic disease.
Definitely. And Dr. Spikes, do you have anything else to add to this?
No, I think Dr. Scott touched on it perfectly. And one other piece I would add as well is that how racism affects physical activity and diet in African Americans is also via the coping mechanisms that they employ. We know that some people eat to soothe their pain. That's a form of coping. Some people become depressed, they internalize their emotions, and it just piggybacks off of what Dr. Scott just mentioned about the effect that this has, this embodiment on the HPA axis, in keeping the body in a constant state of a heightened response. But just so in conjunction with, the lack of physical activity, because let's be honest, when people are going through heavy times, the probability of them wanting to be more physically active and eat right, it decreased substantially. So when you have those things coupled together, it's a recipe for bad outcomes on the cardiovascular and metabolic system.
Definitely. And I think it's just when we talk about these issues of physical activity, stress, and diet, we tend to, a lot of times when we do research, we tend to remove them from what is happening in society. So just thinking about the relationship between physical activity and racism. I'm thinking of the extrajudicial killings that we've heard about, somebody jogging outside and getting killed while jogging, and how that's going to influence the psyche of people. And even for me, I'm very, like, you start getting very careful about going outside and exercising outside, and that is going to does influence the population at large. So now you're trying to figure out to exercise in a space where you want to feel safe. If you're not safe outside, if you feel that maybe you might have people follow you around at the gym, that's also going to be a big problem. So definitely talking about these issues of racism and how they do affect the behaviors that we see in Black people is very important, because the conversation tend to be very stigmatizing, that Black people don't exercise, that Black people don't eat well, but most of the time we don't ask why. Why don't they exercise? Why don't they eat well? When you are dealing with all these different issues, it's quite hard to try to live a healthy lifestyle when you live in conditions such as these. We've we've talked a little bit about both of your research. So let's talk about psychosocial factors, because we tend to ignore them as a risk factor for these cardiovascular and cardiometabolic disorders. So my question would be first for Dr. Scott. So can you talk more about social adversity and hypertension in Black people in general and in Black women specifically? How does it tie into systemic racism? And then are there issues that are particular to Black women that we do not see in Black men, and vice versa?
Yeah, thank you. That's a great question. Obviously, something that's very near and dear to my research is thinking about social adversity. I think a lot of times we have studied health behaviors kind of in a silo, in isolation, without thinking about like the social context of how that's affecting health behaviors. And so, in one of my research papers that was just published, I used a large data set that kind of represents the population of the U.S. And I, looked at what things may predict who developed hypertension. And this was, a young group of women in the study. In my study, the average age was just 29. And so found that women who reported experiencing more discrimination were more at risk for hypertension, at 60% higher odds of having hypertension and blood pressure that was in that above that 130/80 cutoff range set by the American Heart Association. And so in that particular study, in that data set, I didn't have the questions available to interrogate that more and how discrimination was contributing. And so, possible things include sleep. I think there's a lot of interest now in sleep. And sleep should be that time that's restorative and our body's kind of resetting. But if you've lived, all day and experienced these different encounters that are racist, discriminatory, or just even in a system, you think about, Black women make on average 61 cents for every dollar that a white male earns. And you think about that income inequality and how that plays out in your day-to-day, being able to afford, healthy vegetables, being, a gym membership, or be able to do the physical activity that you prefer to do, just all these added stress and how that may disrupt sleep. And so it's very interesting in how, disrupt sleep, not getting enough sleep contributes to hypertension. And so people who are sleeping less hours, if you're working 2 jobs trying to make ends meet, that can also be a factor. And so in that particular study, I was looking at social adversity and did find discrimination as a predictor, as well as sleep continuity, so waking up often during the nighttime. And so a lot of times we think about that with depression, can be a sign, but we don't really have a good understanding of how discrimination affects sleep. And so the further area for study is, are people unable to rest well? Are they waking up? Are they more at risk for depression? That is something to think about. I think as specific to Black women, an area that I'm getting more and more interested in are the pregnancy associated comorbidities. And so I think, we know that women who experience preeclampsia, gestational diabetes, even hypertension in pregnancy, so it doesn't quite get to that preeclampsia or eclampsia stage, are at more risk for having bad cardiovascular health outcomes later. So having things like a heart attack or a stroke. And so, what are we doing with that group of women? So, pregnancy often happens earlier in the lifespan. And so it's kind of like we've had a preview, a glimpse of what may be going to happen down the road. What do we need to do to intervene? And as a, clinician, a lot of clinical settings, do we get a pregnancy history? So no, she's not coming in for pregnancy. She's coming in for high blood pressure, but did we ask about those disorders in pregnancy and how that may put her at risk, set her up for at risk for something, for a heart attack or a stroke later? And so I think that's a big area that's specific to Black females that needs to be studied more, and that we need some specific interventions to target that, to tailor to that group of women to reduce their chances of having bad cardiovascular outcomes like a stroke or a heart attack, or even, you know, thinking about thrombosis like blood clots. So there's been a lot in the news with that related to pregnancy. And so I think that's a window of something that we can focus on in the future. I think one last thing I would add about specific to Black women, I think, is that chronic stress piece, and thinking about Black women who are often we are often the hub of our community. Like, we're kind of in the center, and, you know, between whether it's family, whether it's community, whether it's social life, you know, whether it's church, whatever. And so this sense of having to be the strong Black woman and support everybody else, but how do we take care of ourselves, right? And so I think thinking about self-care and what that looks like, thinking about stress within our network, like how do we prioritize ourselves? Sometimes we're busy managing the stress of everyone else and not doing what we need to do to take care of ourselves. And so making that a priority, that is not selfish, and we deserve to do that.
Definitely. Thank you so much for just this amazing insight into your work, and amazing insight into social adversity and the larger consequences, because now we are getting into conversations around maternal mortality, which has been in the news a lot, just looking at how Black women are dying at a higher rate, like much higher rates, which is very much unacceptable compared to white women. And then if you already come into a system that is biased towards you, and then you already have this risk, and you are coming in with the stress, all these different stressors, we see how things are escalating to the point where they are right now. So before we continue with Dr. Spikes, I just wanted to ask our audience if our audience had any questions about about some of the conversations we had. So I'm just wondering if our other moderators have had questions over social media, or if people in this call have questions. So I'll give you a couple of seconds. So any questions? So if we definitely make sure, if you have questions, make sure to ask them. But we will continue with Dr. Spikes, and I'll let Chichi ask that question.
Dr. Spikes, so I know you mentioned that your previous nursing experience you have experience of working in specifically an ICU unit with regards to like cardiac health. I just want to know more about the stresses and, you know, adherence to hypertensive medications that are obviously very vital for controlling blood pressure in Black people in general. And is there anything in particular that, you know, your research has, you know, found is more unique to Black women with regards to managing hypertension?
Yeah, so it's a twofold answer. So once they came into the clinical setting, in the ICU, obviously disease had already progressed. So at that point, they were more adherent, taking their medications, because they were managing also multiple comorbidities. But my dissertation study actually looked at health behaviors of medication adherence in the context of racism and sexism in a sample of young African-American women. So these women ranged in age from 18 to 45. And what I found was that, well, let me back up a little bit. There are multiple studies that exist that talk about the barriers to adherence in African-American women. And so I wanted to do a different spin. Okay, we know about the barriers, including, you know, competing demands, what Dr. Scott just mentioned briefly, subordinating their health for the needs of others. And just, also this denial piece. Well, hypertension is for the most part an asymptomatic illness, so you don't feel it unless you're in a hypertensive crisis. So those things are all collectively contributors to non-adherence, but the literature was very scarce when it talked about factors that promoted adherence, specifically in the context of, or the social context of, African-American women. So my dissertation actually looked at some of the key factors that are known to impact adherence, including depressive symptoms, social support, resilience, hypertension beliefs, and wanted to see how those things impact medication adherence. And what I found was that women who were actually adherent had lower systolic blood pressures compared to the women who were not. They also, interestingly, had higher resilience scores compared to women who did not. And strikingly, they viewed hypertension as a less threatening disease, meaning that, yes, I've been diagnosed with hypertension, but I don't feel like hypertension is going to take me down. Whereas the women who were less adherent, they held the perception that hypertension was more dangerous, that they were more likely to experience bad effects from hypertension. And what was interesting, because you would think that, okay, if you view this disease as something that is more dangerous and that it could lead to bad outcomes, you would actually improve your adherence. So one thing I did not look at in my dissertation study, which I'm thinking maybe a reflection of that response, is that it was possibly the side effects that they were experiencing from the blood pressure medicine and not hypertension itself. But so that those were the key takeaways from my study. And even though the women who were more adherent had lower systolic blood pressures, their blood pressure was still high. It was still like 129. So it was right beneath the threshold of hypertension with the new guidelines.
Yes.
Okay.
So we have a question. Sorry. We have a question.
I was going to say the same thing.
We do have a question from our audience. So Dr. Commodore Mensa said, thank you, Doctors Scott and Spikes, for your insights. In your opinion, what are some creative ways that we can engage Black women of reproductive age to improve blood pressure control?
Yeah, that's
Go ahead.
No, that's a great question. I think that's a great question for a couple of things. One, I think, as Dr. Spites and I both have mentioned, is that, we often see hypertension develop at younger ages among Black women. And so in that reproductive age span, and then the American Heart Association just came out, with a statement that a lot of young adult women don't realize that cardiovascular disease is still the leading cause of death. So I think there's a lot of work to be done there. A lot of people, obviously, women are worried about breast cancer, not to take anything away from breast cancer, because we know that also kills way too many Black women, but we have to get the message out. And so I think thinking about reproductive age women and where, how we can reach them where they are. And so thinking about connecting with colleges and universities, I think thinking about, sororities and organizations that a lot of young adult Black women may be a part of. And then I think figuring out how to leverage social media, because, for good or bad, social media is here and to stay. And I think just by virtue that we're all on this virtual Zoom call, having this, platform to discuss the cardiometabolic health of Black people virtually, that when we all connected for the most part by social media, that there's a way that we can leverage that to do good, to engage Black women, to education, research, discussion. I think figuring out a way, I think also to increase the representation of people of color in this field, which is another reason why this is so amazing that you guys have organized this Black in Cardio Week, because I think when I'm talking to a patient and we're, talking about physical activity, and I'm able to say, okay, well, what's your, okay. And so what's your plan? What are you going to do about your hair? You know, like thinking through all the things, the barriers that could get in the way, maybe a question that someone who doesn't look like her and doesn't have similar experiences as she does, that may not think about those questions, that would, you know, maybe derail her plan for, you know, beginning physical activity. And so coming up with a hair plan and figuring out what need, you know, those steps need to happen. So I think having more people, more representation in this field, it will help. I think engaging with colleges and universities, sororities, places where young adult Black women are, leveraging social media, I think is really important.
Yeah, and I would like to piggyback off of that too and say, even though we're in the time of COVID, you can still draw from your social groups and you can do things together, physical activity outside, I mean, before it gets cold. But believe it or not, I mean, it's research that shows that when you have accountability partners, it works. So, and also just drawing from that strength. But those, yeah, I agree everything what Dr. Scott said. That those are things, that innovative ways to help increase activity, to help increase awareness, to decrease hypertension in young African-American women.
And I just lift up the work that Girl Trek is doing. When you, Dr. Spice mentioned that, I think about, a week ago, I went on a socially distanced masked walk with 2 other women from Girl Trek. And so we were outside, we were on the trails, we had our mask on, we had some accountability. It was a Saturday morning, it was a little bit cool. You know, if it was just me, I probably would have talked myself out of like, oh gosh, it's too cold. But, we met up and, we got a good 3 miles in of moving our bodies. And so I think there's a lot of organizations trying to do that and not letting COVID, stop us. If anything, it highlights the reason why we need to be doing this, knowing how, the link between cardiovascular conditions and COVID, severe COVID illness, related illness.
Yes, definitely. Dr. Spikes, did you have anything to add to this?
No, I think Dr. Scott touched on it perfectly.
All right, Chichi, I think you had a question.
It wasn't really a question. It's just more the fact that as a young, Black woman of reproductive age, I feel like these are very, very important, conversations that, we do need to be having, because like Dr. Scott said, that generally is just a lack of representation when it comes to not only just Black people, Black women especially. So it's good that to have these kind of platforms, have these organizations that are, raising awareness, that are trying to, more so educate the masses, because something I do think when it comes to, cardiovascular health in a sense is that, it's like some people know, they're aware of it, but then they don't know the actual, the deeper implications and, how it, manifests in different communities differently. So I definitely feel like this, even though I'm a moderator, I feel like this, I'm just a sponge right now, just absorbing all of this, all of this knowledge, all of this experience, all of this expertise. Yeah,
definitely. And like you did mention something, leveraging social media. It's just going to be like, it's so interesting because we were actually talking about this paper with Dr. Mary Cushman, who is my advisor, is very, very much involved with a lot of the work around cardiovascular health and women. So we were talking about how do we actually raise awareness, because it feels like people don't understand that these diseases are killers. And I think Doctor, you did mention something about the disease being, Dr. Spikes, you did mention that these diseases being silent killers. So you don't necessarily feel them unless you are in a crisis. I think that plays into that. Just people feel fine, even though they are not fine. And I have like experiences, like family experiences with people just letting their blood pressure just go up because they don't realize that blood pressure is a risk factor for a lot of these diseases, like heart disease, stroke, and so forth. So, but going back to social media, we have, I think we have to start learning more about science communication. And I think we had, like I mentioned that we had a conversation about it yesterday, just in a way that science communication, like there's a way that is very specific as to how you communicate over social media, and it depends on the platforms that you use, and it depends on your audience. So for instance, you know that maybe the older generations, you can find them on Facebook, and then the millennials and late millennials, you can find them maybe on Twitter, or and then TikTok is for the younger people. So you have to be able to move across these audiences and understand how you engage with these audiences, remembering that you have this cultural aspect of it. So you have to be knowledgeable about the culture, like Black cultures. So right now, I feel like social communication that is happening online is you have these amazing science communicators that people should definitely reach out to. You have STEM Noir, for instance. You have the researcher, for instance. You have these amazing Black women. You have Raven, who is who mixes hip hop with messages of health. So you have all these women that are doing interesting work. These Black women doing interesting work. So I think it's up to organizations, big organizations like the American Heart Association, to reach out to them and see how they can work with them so that the message can be broadcasted to a larger audience. Before I ask you, I'll ask the next questions. I just wanted to see if the audience had any other questions for our speakers, because we are talking about cardiometabolic health. Very important. Any questions? Over social media, do we have any questions? I'm sure that we'll have them later. If we don't, I have, let's talk about your careers as as postdocs, because that's also very important, and also talk about some of the issues that you do encounter as Black postdocs, and also some of the issues that you did encounter when you were in grad school. So my first question would be to know what was that specific moment that made you realize that you wanted to have a career into what you are doing right now? What's made you realize that, yes, I want to further my education. Yes, I want to get into cardiovascular health? Because I think it's very important for younger people to know what made us who we are today. Yes.
I believe in the power of stories, and again, going back to my days when I was in management, I will never forget this story as long as I live. But if we had a patient on our unit, she was a 29-year-old African-American female. She had just delivered her baby, which was about a month old at that time, but she developed peripartum cardiomyopathy. And she had a pre-existing diagnosis of high blood pressure, was not managed, and long story short, her heart functioning was only at 10%. So when the medical team was rounding, I accompanied them. That, they were just going to let her know that at this point it's nothing more that we can do. You're too weak even to undergo anesthesia. Like if we tried to even put you under, you would die because your heart was so weak. And it broke my heart because, like I said, 29 years old, this whole family dynamic was now disrupted. Her mother did not live in Georgia. Her mother lived out of state. So this meant the mother was going to have to eventually assume responsibility for these 3 babies, with her daughter now going home on hospice to pass. And she eventually died like 2 weeks right after she left the hospital. And, it disturbed me to my core. And I often ask myself, like, how did she get here? 29, advanced heart failure, and dying at 29, like this just should not be. And so when, as Dr. Scott mentioned about the power of engagement, when I talk about that story often, it really piques a lot of young Black women attention, because they are oblivious in understanding or realizing that heart disease is the #1 killer, and that Black women especially are particularly vulnerable. So that's what, catapulted me to want to go back to school. That was a big decision because I had an established career. So to go from a career to back to now student status, it was hard, but it is worth it. And for my postdoc, I decided to go into CV cardiovascular epi to look at these large data sets so I can see what is going on and look at these trends, because that would just furthermore complement the clinical piece that I, have already. And I just felt like my purpose was bigger than the four walls of a hospital. And what I needed to be doing was out to keep these women from going in to this health system. If we can do this primary prevention and keep them from getting to that point, I feel like I've left a thumbprint of my legacy that was something meaningful while I was here.
Definitely. Dr. Scott?
Wow, that's a really powerful story that Dr. Spites shared, and I really appreciate that. I think for me, I try to think back, and I think I spoke to it earlier, just really kind of came out of the clinical experience as a nurse practitioner, and I don't, there's not one in particular, story that I can drill it down to, but there's just this pattern of patient encounters, patient visits, where, we're having this similar dialogue repeatedly and realizing that we don't have the tools to fix the problem, right? And so, talking about medications and talking about health behaviors, but just feel like what I had learned in school was not adequate to really address the problem. It was still, I was still seeing these women come back with these really high blood pressures, and felt like there was more that needed to be done, that, the research that had been done just was not sufficient. And so, and as Dr. Spite said, it was a big decision to leave an established career to go back to student status. But I also knew within my heart it was the right thing to do. Like, I wanted to be able to have that impact on a larger level. So, as a clinician, a lot of times it's that one-on-one, which is very, the primary care provider to me is really underappreciated for what they do as far as in our health system. If you have that continuity of relationship, you really get to know people and you can really see change. I think because I was seeing the same pattern of problems, I want to be able to address it on a larger scale. And that led me to going back to do the PhD program. And now in my postdoc is at the University of Pittsburgh. And it's kind of odd because it's in the Department of Psychiatry, but it's with a group of scientists that study cardiovascular behavioral medicine. And I really appreciate that this group of psychiatrists and psychologists are all coming at it from the place of understanding stress and how that affects health behaviors, and how does that, impact the approaches that we take with helping people to make, have better health behaviors. And so I really liked integrating that piece of stress and context and social systems with health behavior to improve cardiovascular health.
Definitely. So I do have a quick question, or we do have a question by Jason. How do you balance being a postdoc and a clinician at the same time? How does it work?
Yeah, well, for me, so I am very new into the postdoc. I am only this is month 2 or 3. And so I currently am not practicing because I changed states. So the whole process of getting licensed in the state and exploring what practice will look like. I did practice throughout my PhD program, but just very, it's a challenge, right? And so I practiced very little, about part-time. So about 1/2 day a week, I would say. But it took finding the right practice, the right place that would allow me to continue to practice. It's been important to me up until now to try to maintain that practice, because so much of my research is informed from those conversations and interactions with patients. But I do believe at some point, it comes where you have to really dig deep into the research. Sometimes you have to go 125% into research. And so I don't know what that will look like in the postdoc period. Fortunately, I do have, almost 15 years of experience as a nurse practitioner. And so if I press pause now, it may be something I'm able to pick back up as I move into more of a faculty role. But right now as a postdoc, I am jumping into research and trying to launch my research career so that I can continue to do the work that I hopefully will make a difference for communities and for women of color.
Definitely. Dr. Spikes?
Yeah, so I work per diem during the PhD program, so maybe 2 shifts a week. But now that I'm in the postdoc, I had to abandon the clinical practice because it was too busy. It required so much time, so much reading. And as Dr. Scott noted, when you're trying to establish your research career, like you really have to have all hands on deck in just this one pot. You don't have time to really spread yourself into the clinical. I miss it, but just right now I'm just full-time research, so I'm not doing clinical practice at this time.
Definitely. And since we are also trying to, I guess, being a lot of us are trailblazers in these spaces. So just like being the only one, and we are trying to bring in these younger people into doing some research, being clinicians or being postdocs. My question for you would be, what advice can you give to an undergrad or a young researcher just starting out? What kind of advice would you want to give them? Or if you had known what you know now, what kind of advice would you give to your younger self?
I would say that it's hard, but it's rewarding. Anything that challenges you to grow, it's not going to be easy, but it'll be worth it when you look to see the reach of your work. Right now I'm working on 2 projects, 1 paper I'm finishing up. Now I'm super excited about, it being disseminated and, just highlighting these stressors and, what's going on with Black women, because it's just just being honest, undervalued, marginalized group that has been neglected when it has come to health research. And the more representation we have of people who look like us in this space, we can make a difference and change that narrative.
Definitely. Dr. Scott?
I think, I think my piece of advice would be to really listen to yourself, to pay attention to the things that you really enjoy, and that really nurture you, and follow that path. So for me, I tried to, I remember, in nursing school, between the first and after the first year or first semester, there's this internship, and I tried doing the ICU because I thought, that's where smart people go. You go to the ICU, and it was not for me. It's just, and so, Dr. Spice, but, I think, it's not thinking about, where I'm supposed to be or where everybody say, oh, you will be so good here, but what feels right for you. And what felt right for me was being in the community, being in a primary care setting. Like that is that is where I need to be. And so, even now I, identify myself as a preventive cardiovascular scientist. Like I'm all about the prevention. I'm all at that, that front end of that research spectrum. And so, so really listening to yourself. Like if I had listened to myself, like, even everybody was saying, oh, ICU would be great. Like I had my doubts. And if I would have listened, I would not have even wasted that summer. I could have done something that would have, contributed more towards the pathway that I end up going. And so trusting that, when you have that little feeling in your gut that this is where I should be, or this is what's next for me. Same kind of thing, like, applying to PhD programs, people are like, why would you do that? Or, that's, you want to do that? You want to go do research? Like, that's not gonna, but listening to my gut and knowing what was right for me, the next step for me. And so learning to trust that piece of yourself, and learning to find out how you make decisions and what works for you, and listening to that.
Definitely. And I'm going to ask if Chichi, as a comment?
I feel like this conversation has, this has been a very fitting conversation for this day of, Black in Cardio Week, and something that, has resonated with me from obviously both of your vast experiences is just the fact that, there is a lack of, representation. There has been, somewhat of a, failure to Black women as, as a under, represented and neglected group, but something that, I do hope that, the viewers who have, tuned into this session, especially, young Black women, is that, when you going into research, is sometimes the purpose is bigger than you. And that's something I feel like I've taken from, both of your stories and both of your experiences, is that, this will hopefully bridge the gap and, will fill in, some of the lack of answers as to why, Black women, we are more at risk of having, hypertension, why we are more at risk of, developing complications in pregnancy, why we are more at risk of, developing these cardiometabolic risk factors. So yeah, this has been a very enlightening session, definitely.
Definitely, and I'd like really truly appreciated just this conversation, because I guess like I said, sometimes it feels very isolating when we are in these spaces, because we tend to be the only ones sometimes in these spaces. And so really knowing that there are people doing research in different universities, people that you can talk to, people that you can collaborate with, because again, the way, like in science, in research, collaborations are everything. So that's one thing I really want the audience to get, at least to get from Black in Cardio Week, is that find collaborators, find people you can work with on this project. We have talked about all these interesting projects, Dr. Spike's project, Dr. Scott's project. If you like their project, if you feel that it aligns with what you want to do, definitely contact them and see if you can work, because we have to start publishing papers on these issues. We have to start having people get tenured, and it's very, very important. But thank you so much for coming and sharing your stories and giving us important advice about cardiometabolic health. And we hope that our audience will keep on engaging and commenting and talking about all these different issues, because like you said, cardiovascular diseases are the #1 killer for Black women and for Black people and for people all over the world. So we need to start talking about risk factors, preventable risk factors. And we need to start talking about risk factors that sometimes we don't think of, like stress. So thank you, and I hope that you, both of you, will still be there for the reminder of our event. So definitely interact with us and engage with us. And thank you. So this is the end of our Q&A. Have a nice day.
Thank you.
Hi, everyone.
Thank you for organizing.
Yeah.
Definitely. Bye.